everybody. Welcome to our session on decoding the signals, understanding your WM test results. I'm really honored today to introduce our speaker. Dr. Rachid Baz is the myeloma section head in the Department of Malignant Hematology at Moffitt Cancer Center in Tampa, Florida. In addition, he is the co-director of the Pentecost Myeloma Research Center and professor in the Departments of Oncologic Sciences and Medicine at the University of South Florida in Tampa. We've also had the pleasure of having Dr. Baz come to some of our local support groups in Sarasota. So he's listed in their WM Physician Specialist Directory. So I'll turn it over to you.
Good morning. Still morning, right? All right. So, and before I get started, I want to thank the IWMF for the invitation to come. It's a beautiful venue, and they always do a great job. I mean, the room was packed, and lots of excitement. I also get to speak after the Pope. The Pope left, but I get to speak after the Pope, and that's pretty cool. I'm a Catholic, so it's really neat. It's a little stressful, right, to speak after the Pope. So but my lecture is a little more of one-on-one type lecture. So it's basically trying to understand a little bit what all the medical terms really end up meaning to you, and we'll have time for questions, so if you have questions, we can answer them at the end, and we can always talk after the lecture as well. So decoding the signals. All right, sounds good. Okay, before we get started, one more question. How many of you are from Florida, live in Florida? Oh, so the most of you live in Florida, yeah. All right, awesome. So let's talk a little bit about WM. I showed this slide to a lot of the trainees, and WM is an uncommon condition. Perhaps a little bit outside this room, it's uncommon. In this room, kind of common. And actually, as Steve said earlier, it's very difficult for an orphan condition to get a lot of attention, and that's, I think, especially when you think about NIH funds and grants and research, a lot of it goes to support things that are more common, like breast cancer, lung cancer, and my wife's a breast cancer oncologist, and she's at like national meetings. But it's different, it's different for Waldenstrom and WM. But I think we've done a lot of good, despite the little bit of attention. And I think it's thanks to IWMF. As Steve alluded to, there's a familial predisposition, so about 20% of the patients will have, first-degree relative who's got lymphoma or myeloma or something along the spectrum. And the main risk factor is IgM-MGUS, and I'm going to define this term in a little bit. So, some of you have heard from Maury, I think yesterday, correct? So this all should be not news to you, correct? This is a little bit about pathophysiology. If you think about the development of immune cells in our body, B cells are types of lymphocytes, and through their maturation, they become plasma cells. Plasma cells produce antibodies, and we'll get back to this. And somewhere along that path is where that cell of origin, or basically the cancer turns on, and that's where we get this lymphoplasmacytic lymphoma, or we call WM as well. This is a little bit more crowded, but basically the diagnosis relies on identifying a lymphoplasmacytic infiltrate, and I'm going to define this. Lymphoplasmacytic has two words, right? Lympho, basically lymphocytes-like, plasmacytic, plasma cell-like. And, kind of goes back to maybe, Steve's last slide. They said, well, there is, 2 types or 3 types of WM, and some are, B cell-like, and some are more, plasma cell-like. And the infiltrate under the microscope, not at the genetic level, but under the microscope, can look like both. And then we call it lymphoplasmacytic when it does. At the genetic level, there are 2 distinct groups, and you can separate them a little more. But at the under the microscope, just looking at those cells, it looks like both. And then we have an immunophenotype. So these are surface markers on those cells that we can identify And that has the expression of, say, CD19, surface IgM, and then CD138 and CD20. And there should be an IgM monoclonal protein. I'll talk a little bit about this in a little bit. And then those studies, have you heard quite extensively now for the past couple of days about MYD88 and CXCR4 mutation. Things have changed a little bit. In the past, we used to require a certain amount of lymphoplasmacytic infiltrate in the marrow to diagnose WM, and a 10% cutoff was what was historically used. And there's nothing magical about 10%. A bunch of doctors sat in the room and said, oh, 10%. It could have been 5, 9, 15. So nothing biologically meaningful was existing about 10%. And the new classification now omitted the 10%, recognizing that there are patients who have less than 10% in their bone marrow of this condition, but they still require treatment for a variety of conditions that can come along with it. This is where we talk about hematology now, so a study of blood and bone marrow diseases. So very briefly, if you spin a tube of blood, or if you let it sit for a long time, what's going to sit down is that the heaviest stuff is usually the cells, and the red blood cells sit at the bottom. And then there is this kind of a grayish area, which is the white cells and the platelets, and then on top is plasma. And plasma contains basically albumin, nutrients, proteins, hormones. And then if you spin plasma further and you remove the clotting protein out of it, you get serum. So when you hear things like serum viscosity, it's basically the viscosity of the serum itself, which refers to the protein in our blood that exclude the clotting factor. In fact, actually, for most of the time, the plasma viscosity could be increased. We measure the serum, but in reality, sometimes the viscosity of the blood can be increased if there is too much red blood cells. But this is other conditions that are not quite Waldenstrom. The hematocrit, which is what you see, by the way, on your complete blood count, is basically this percentage of red blood cells. So if you think about this, in this case, you kind of roughly, maybe it looks like about 45%. That's about right for most people. And from that picture, that's kind of what it's meant to look. All right, so what are the types of cells in our blood? There are white blood cells, which is part of our immune cells. Red blood cells supposed to contain hemoglobin, and the hemoglobin carries the oxygen. So red blood cells is what carries oxygen. And hemoglobin is a protein that basically ensures the delivery of oxygen to the tissue and the removal of carbon dioxide from the tissue. And that exchange then happens in the lungs, where you exhale the carbon dioxide, inhale the oxygen, reattaches to the hemoglobin, and then that's how you can get oxygen to your tissues. So when someone has anemia, that's usually when the red blood cells, and actually mostly we measure the hemoglobin, is low. So meaning that their ability to oxygenate their tissue is less. And so as a result, the heart's got to pump the blood more, and then you kind of feel tired. And that is the main symptom of anemia. Platelets are the small corks in the blood that stop bleeding. If the platelets get very low, you are at increased risk of bleeding. It turns out, I think it's for evolutionary nature, that we make more platelets than we really need. So man was a hunter, and if you get injured and you bleed out, then you die, so you don't evolve. As a result, if we have more platelets than we need for our lifestyle. Our lifestyle is we watch TV and surf the internet. Mostly it's done sitting. It doesn't involve any injuries. And but as a result, this higher platelet count than we need may be potentially more heart attacks, more strokes. So that's the flip side of things. But if you think about it, if your platelet count, the normal numbers could be 150 to 400,000, and if your platelet count's over 10,000, you shouldn't bleed spontaneously. If it's over 50,000, you can have surgery, and you shouldn't be at increased risk. All except perhaps neurosurgery, where we want the platelet count to be over 100,000. So for most of the time, we have more platelets than we need. But a lot of times, our treatments lower the platelet count, and patients worry that, well, my platelet's too low, but it could be 80 or 90,000, which is actually still pretty good for even if you needed, surgery or, a major intervention. Some of those thresholds may differ depending on whether somebody's on blood thinners, and obviously then the thresholds are in terms of what's going to be meaningful bleeding are going to be a little different. But just so that you can keep in mind that actually we make a little more platelets than is needed, so so if it gets low, it's usually not a lot of reasons to panic. If it gets really low, obviously, then we need to sort out what we can do about it. Neutrophils are infection-fighting cells, and usually they protect us against bacterial infections. And a lot of treatments, like bendamustine, for example, notoriously lowers the neutrophils. Lymphocytes are helpful in fighting viral infections and helpful actually with some immune responses. And now actually we try to harness them to attack the cancer in things like CAR T therapy and bispecific antibodies. And they will be elevated in some viral infection. Occasionally, some lymphoma will produce, some of those lymphoma cells that look like lymphocyte into the blood, and that could be something we monitor and we see. So this is a little bit how blood formation happens in our bone marrow. If you look at a chicken bone and you break it, there's some red stuff in the middle. That's the bone marrow. The red marrow is where you make your blood, where we all make our blood. And at least as once after the fetal stage, in the fetus it happens in the liver and some other organs, but in basically anybody who's born, it's usually going to happen in the bone marrow predominantly. And we have bone marrow in all our bones, more bone marrow in our larger bones, as you can expect. And so a multipotent, stem cell is going to give rise to two lineages, a myeloid lineage and a lymphoid lineage. Myeloid lineage accounts for the production of red blood cells, platelets, some of those neutrophils, and some of those other types of white blood cells. And then the lymphoid lineage gives rise to lymphocytes, and lymphocytes, we said, gives rise to plasma cells, and plasma cells produce antibodies. So that's what that picture is showing you. This is how basically our bone marrow production of blood is formed. The type of antibody our immune system produces is 5. So IgG is the most abundant type, and there are 4 subtypes of IgG, and IgA is usually found secreted in mucosal areas. IgM is on the surface of the B cells, and it's secreted early in a response to an infection. And then after the early stage, then it will transition to producing IgG against that infection. So IgD is bound, and it's usually IgD and E are at low level in our blood, and some patients will have elevation from, say, for IgE as a result of allergic, responses. But parasitic infections are not common in the U.S., so it's not a likely situation. What's important to remember is that IgM comes in a pentamer, 5 structures attached to each other. And so that's why it could lead to this viscosity. If you have this very large product, and it's kind of hard to clear through blood vessels, and if there's a lot of it, then it can make these lots of pentamers. So we don't commonly see hyperviscosity in patients with myeloma who produce high levels of IgG because it comes as a single protein. And for IgA, we see it a little more frequently, but where we do see hyperviscosity is usually for WM, because that pentamer is how it's structured. So the way to simplify it, this is the top part is a normal state where you have a lymphocyte that matures into a plasma cells, and the plasma cell produce an antibody. The counterpart for all those things is a cancer of lymphocytes called lymphoma. WM is a type of a lymphoma, and a cancer of plasma cells called myeloma, and the protein that is produced in the case of WM is IgM, and we call it an M spike, and it's a monoclonal protein. And monoclonal means one clone. Have you watched Star Wars? Star Wars, the clone wars, and there's all those stormtroopers, they're all like same height, same features, they look the same, that's a clone. In biology, a clone has features of cancer. Those cells are too much alike and actually come from one mother cell, so to speak. So these are some of the symptoms of WM, actually. So some of the symptoms could be related to having a lot of involvement of the bone marrow with this lymphoplasmacytic infiltrate, and so there could be not enough space to make blood, so anemia. Fevers, B symptoms, we call those fever, sweats, weight loss. And everybody sweats in Florida, so then everybody asks, well, how much sweating is, a lot of sweating. And I tell patients, drenching night sweats. So you wake up at night and you need to change your clothes. That's drenching night sweats. Otherwise, if you're just sweating, you're just like me and you're in Florida and it's hot, okay? Enlarged lymph glands, enlarged organs such as the liver or the spleen, and any organs could virtually be involved theoretically, although these are the more common ones. And then there are symptoms that relate to this IgM that is produced, and if it's too much of it, sometimes it gets that the blood is viscous, and symptoms of viscosity means difficulty concentrating. You start thinking, well, headache, visual changes. Cryoglobulins is basically antibody that deposits in the cold. Cryo is cold. And in the cold, it deposits. So patients with cryoglobulin, what do? They move to Florida. It's warmer, so that helps actually. I'm not kidding, it does help. Cryoglobulin happen in about, we detect them in the blood of about 20% of patients with WM, but actually they're clinically significant in about 2%. So it's uncommon, but to have symptoms from it. Symptoms could be a rash and a painful rash, and it needs to be treated at that point. Cold agglutinin is basically a similar concept, except instead of depositing in the tissues, what happens is that it attaches in the cold to red blood cells, and it results in the destruction of the red blood cells. And you would say, well, our body is warm. How could it destroy red blood cells? Well, part of our body is not as warm as the rest of it. So usually the tips, the earlobes, like the feet, and the temperatures can be a little bit lower. And if you're in Florida, it's not as huge a deal, but sometimes it does get a little cold in the winter. And so there could be more destruction of red blood cells. A lot of times patients will notice, it's happening more in the winter. But, and that will need to be managed. It's a hemolytic anemia, so there is destruction, hemolysis of red blood cells. Neuropathy is nerve damage, and there is many mechanisms for nerve damage in patients with WM. Usually there could be, for example, deposition in the tissue, or there could be an attack of the IgM protein against myelin-associated glycoprotein, so that's called MAG neuropathy, and that is treatable. So we will ask a lot of times patients about it, are you having neuropathy? But also sometimes our treatment causes neuropathy, so we have to be aware of which is which. Amyloidosis is also protein deposits, and it can occur in myeloma, but it also occurs in the WM side of things, and it has implications for treatment choice. Fortunately, not very common. And really, to diagnose WM, I kind of think about it like a piece of a puzzle, and it has to be that the pieces fit. So it has to be that you look at the patient, talk to them, examine them, and look at the labs. Is there anemia? Is there any signs of organ dysfunction? Look at the images. A lot of times now we're doing PET images, and then also look at the bone marrow pathology, and we're going to focus on the bone marrow part. This is a little bit our common workup, and there is ways to test for a lot of those symptoms and some conditions that we brought up, like cryoglobulins and cold agglutinin. And that gets a little bit tricky because you have to make sure that those samples are collected in a warm temperature and left in a warm temperature until it's ready to be analyzed. So the lab has to be notified, and the phlebotomy area has to be notified as well if this is what we're looking for. The urine electrophoresis is not commonly positive. I like to do one at baseline, but after that I don't typically repeat it. Most patients will not produce enough protein in their urine, but sometimes there could be a lot of good protein being leaked there, and that could point to maybe amyloidosis could be coexistent. So I think doing it once initially is fine. Routine blood work like CBC and CMP, which we'll talk a little bit about. We'll talk about a PET scan and this, dreadful bone marrow business, right? All right, so let's talk about the bone marrow. I tell patients the bone marrow is like a pound cake. If you stick a needle in a pound cake, stuff from the pound cake will stick inside the needle, and you can look at it under the microscope. And we go there at the hip bone. The reason we go there is because there is no major blood vessel there, so it's actually safe. And the main side effect, is that it can hurt. right? Actually, I've surveyed a lot of my patients when I was in Cleveland before I came to Florida, and we did the bone marrow with just like putting numbing medicine. And then I asked patients, how was it? And about a third would say, nah, not a big deal. I could do it again. I didn't feel a thing. Another third would be like, well, it kind of hurts, but if I need to have it again, I'll do it. And the third would say, don't ever come close to me with this needle. And I figured that a third would say that that's too much. Actually, at Moffitt, we do the marrow with sedation, so you're out, kind of like having a colonoscopy. And I tell patients you get this propofol, which is the same thing that Michael Jackson had, but we will watch you a little better. And then you'll be asleep and you don't feel the pain. The pain is that when you draw the bone marrow, it could be intense pain, but it lasts a few seconds, but it's so intense. And as a result, it's preventable with sedation. So we have that option, and actually most patients want sedation from my experience. Actually, the point of doing the bone marrow is to confirm the diagnosis, to get all this genomic information that is prognostic, predictive, kind of help us choose the right treatment for the patient at the right time. And sometimes we need to confirm response because, as Steve was showing, sometimes we see the IgM improve, we're real happy, but the bone marrow maybe hasn't improved as much. And then that's still something we need to tackle. And then we sometimes have to deal with low blood counts. And maybe it's from Waldenstrom, but sometimes it's not. And so we need to sometimes look in the bone marrow because that's where blood's produced to find out the reason why. So the bone marrow's got two parts. There's a biopsy, a bone chip. And the bone chip is really, something that, can give you a representation of, how much involvement there is. That's really where you get it from the bone chip. It can be stored indefinitely, has to be decalcified. And you can't really do a lot of the molecular tests once they decalcify it. On the other hand, the aspirate is the liquid part that gets sucked out, and that's where you get a lot of those molecular information from. So the key thing is that when you're having a bone marrow, make sure that all those genomic tests that you need are going to be ordered on it, because once you have it, it's going to be a little harder to get it after the fact if it wasn't ordered. We can look at the adequacy of the aspirate by looking for what they call spicules. Spicules is little chips of bones. And if you see them in the aspirate, that means, oh, we got a good draw here. But if you don't, that means, well, maybe a lot of it's blood and not representative of the bone marrow space. And in that case, that's not so great. We can, look at morphology. That's important on the aspirate because sometimes there are additional conditions that can occur along with WM, and myelodysplastic syndrome or precursors of it, or it's like basically marrow failure syndrome, are going to help clue us sometimes on a direction to take with treatment if we are worried about that. So this is the genomic testing, and Steve and I think Maury talked to you guys about it. I think initially we only focused on mid-88, and then we started focusing on testing for both mid-88 and CXCR4, and then we include now P53. We have a lymphoma panel at our center, and actually it has a bunch of different genes, and it can be very helpful to have this information when you kind of make treatment decision. It's just not just looking at MYD88 and CXCR4. And then, by the way, those mutations are always classified as either mutant or wild type. Mutant, that means you have a mutation in the gene. You are not mutant, okay? A mutation in the gene. And wild type is you don't. You are not wild. So it is just a terminology. And there's different mutations. In MYD88 mutations, the most common is this L265P, but other mutations can be found. And the same for CXCR4 and the same for P53. And different mutations carry different information prognostically and potentially predictively. Means how does it impact our treatment? A lot of times in oncology, and for a long time, it was very hard to distinguish other conditions. IgM, MGUS, I kind of say that 10% is still written here, but actually it's mainly that there isn't LPL involvement in the bone marrow. Marginal zone lymphoma can be hard to distinguish. Actually, the Southwest Oncology Group used to do studies, clinical trial for WM, and they included marginal zone lymphoma. They included it because back in the day, you couldn't really have a lot of genomic tests to differentiate them. And from the pathologist's look, you couldn't tell for sure which it is. And when the pathology was sent centrally to be reviewed, there was so many discordant cases where the local pathologist called it WM, but then centrally, oh, well, this looks like more marginal zone. And so it can be hard to distinguish. And sometimes marginal zone can produce an IgM protein, so it's something to be aware of. IgM myeloma is a little bit easier to distinguish from Waldenstrom, and CLL is a common entity, but it is also easy to distinguish from WM. All right, so PET. It basically, most common PET we use radioactive sugar, and it gets injected, and then we wait a little bit and we take pictures. How many of you had a PET scan? Okay, a lot of you, good. So you take that radioactive sugar and you see where it went. And the thinking here is that the radioactive sugar went to areas that take up sugar more, hence maybe cancer. But it's not exclusively cancer. Actually, the radioactive sugar could be taken up by areas of inflammation, infection. And with any test in medicine, there is what we call an incidentaloma, which means we find things incidentally. We weren't looking for it, but then the radiologist will mention, well, the prostate's got some uptake, and look, the tonsils got some uptake, and then we have to chase those to make sure it's nothing serious, and then we have you see the ear, nose, and throat doctor who looks with a camera and says, everything looks good here. But so sometimes there is, with a good intention, we want to try to find where cancer is, but we detect little things that are ditzels that don't mean much. So not everything on the PET's a source for worry. And so talk to your doctor. A lot of times that can be, kind of explain, oh, no, don't worry about this one. We see a lot of this, and that's not very important. But this one study found that there is actually nearly half the patients have lymph node that have uptake on PET. I think a lot of this, cohort maybe included patients who had multiple treatments. And, I think my experience, I'd say it's a lot less than this. But I think it's key that it's important to recognize and, not to be confused for other cancers also. And this improves with treatment. And I think it is better than CT in terms of picking up areas, because sometimes with CT, we will not see the lymph node be big. The CT can pick up size, but the PET scan can show you uptake, and so that tells you, well, maybe that lymph node's involved, but it's not quite big, and that's why PET is a little bit better at picking up those areas. All right, we're going to push into lab results. This is what our complete blood count computer screen looks at Moffitt. So we talked about the white cells. I met a physician in Canada who wanted to remove the white cell from the printout results. Because what happens is that a lot of time it would be like marginally low and all the blood counts were normal, and that he would get those patients referred or, oh, their white count's low, can you evaluate them? And there was nothing wrong. If all the differential looks normal, if the white count's a little bit under the range, no cause for concern. So the white count by itself is basically what I'm trying to say, does not mean a whole lot. What matters is those other cell types. Is there abnormal cells? Is there a low neutrophil? Is there a low lymphocyte counts? And these are the things that we look for, and we define some of those. Hemoglobins, basically oxygen carrying capacity. So the ones circled is the ones I think you should look at. But there are some red cell indices, like the mean cell volume, the mean hemoglobin concentration, the red cell distribution widths, and sometimes they come back always a little bit abnormal, red or flagged on the computer. Do not worry about them. Those ones, those three, don't worry about them. Okay, it's sometimes it just kind of results. Oh, okay, what does it mean? Don't worry. It usually doesn't mean anything serious. Sometimes the MCV is high because of rouleau formation, so meaning the machine counts as one big, glob of red blood cell and as one large cells, and then as a result, it thinks, well, there's those large cells and there's some smaller cells. The CMP, the first part is basically sodium and the potassium and the chloride, and these are the electrolytes. The blood sugar is self-explanatory. We look at kidney function and some of the blood proteins like albumin and globulins, and then the liver function, AST, ALT. And there's many reasons some of those could be out of whack. And sometimes it's related to our treatment, but a lot of times it also could be not related. The most common thing we see in Florida is people not drinking enough water. Okay, drink water, especially in the summer. Then you get a little dehydrated, the BUN goes up, the creatinine sometimes inches up, and I think this is where, we can pick up some of those dehydration, maybe low potassium, and if somebody has diarrhea, all of those things become more important. When we want to try to measure the protein from Waldenstrom, we look at that M spike or the IgM level, and this is with an explanation of the M spike. So the top graph is basically if you did an electrophoresis of protein, so you run proteins through a gel from the serum, and it will separate proteins based on their size, and then there's computer tracing that will put it into a graph based on how much of that protein is present. So the most common protein in our serum is albumin. You see, that's the sharp peak. And then the rest is globulins. And normally you would see those bumps in globulins. But then if you see another peak in the gamma fraction of globulin, that's where immunoglobulins reside. And that usually tells you, well, hey, there's an M spike here, or a monoclonal protein. There's about 6 names for M spikes. So monoclonal gammopathy, monoclonal protein, monoclonal band. All labs, each lab uses a different terminology. It means the same thing. And you can quantitate this M spike by basically looking at the area underneath the curve. And then the immunofixation is basically where you cut out a piece of the gel and you try to attach anti-IgM, anti-lambda, anti-kappa, and in this case, it's IgM and lambda, which is what makes the M spike. Now, this is graphically how the lab reports it. And it reports, in this case, the M spike concentration is 0.6. Our lab uses gram per deciliter. Each lab might use a slightly different unit, but that's the most common one. And then the electrophoresis, it says, well, there's a monoclonal gammopathy. Again, monoclonal protein, M spike, M band, same things. And then electrophoresis is telling you, this is IgM lambda for this patient. Okay, sounds good? Maybe? Okay. All right, now, if you look at the total IgM in the blood, it's made of the IgM produced by WM, so the clonal part, and that's what basically the M spike is supposed to measure. And then it's produced by the non-clonal IgM, but usually that's so little of it. So at the end of the day, you can approximate what is produced by the Waldenstrom by really measuring the total IgM. For patients with myeloma who have IgG, a little more complex because we normally make more IgG. But because the production of IgM by the normal immune system is not so high, the IgM could be the surrogate for that electrophoresis. You get the test results a little quicker. But there is some pitfalls of IgM versus M spike measurements. So we look at both in our center. And sometimes, there's 2 values and maybe there is less likelihood for error when you want to interpret them. The response criteria, these are the older response criteria, and they've been updated, but basically they really focus on the IgM. And so basically the CR is where the IgM normalizes, and you've done that immunofixation and it's negative, and then you've done the bone marrow and it looks normal. VGPR is when there's a 90% reduction in IgM or is gone to normal. And then again, if you look at, for example, scans, there is no detectable, lymph node enlargement and so forth. And there's criteria for partial and minimal response and, worsening of the disease. All that is based on the IgM. So the IgM for us, it kind of functions like PSA would be for prostate cancer. And more means there is more cells that produce it. That's not good usually. Although there are instances where there could be a flare reaction, and maybe not always there is more cells producing it. Less usually means there is less cancer. And less cancer, it's a good thing. Although sometimes, also what could happen with the surrogate marker, they're not perfect. Less could be that, there is less being produced, but in the bone marrow, there's still quite a bit of WM cells. So it is not always a perfect surrogate. So sometimes we got to look at the bone marrows as well to make sure that these are matching up and things are making sense. This is a little bit how we would track things. So this is an actual patient who I think had DRC, so it's Cytoxan, Rituxan, Dex, and you see a response. And this is what we call a VGPR. French came up with it. Very good partial response. So meaning the IgM and the M spike have improved by 90%. So that's pretty good. Actually, complete responses, as you've seen from the other slide, are not very common. Although we're seeing a little more of them now, but it's not common. What we see a lot more is partial response and very good partial response, and they're very good still. So there are some pitfalls in monitoring IgM and M spike. So if you're using IgM and at the low M spike concentration, it still could be within the normal range. And so it's hard to interpret whether things are really higher because of more cancer producing more, or whether it's just the immune system that fluctuates. At high concentration, there could be clumping, especially in the patients who have cryoglobulins, where it precipitates while sitting in the bench in the lab. And as a result, you can get a falsely low value. And then there are discordant responses, which we talked about, which is especially things we see with Velcade or bortezomib, and where the bone marrow gets actually not changed, but the IgM is a lot better, and you're kind of a false sense of security that, well, we've done great. But then you're wondering, well, why is the patient still anemic, for example? There's a free light chain test. The free light chain test is basically measuring this part of the immunoglobulin that is a smaller part called the light chain. Two types of light chain, kappa and lambda. And usually your WM's producing one of them, and one's going to be a little elevated. And it has implication is that actually patients who produce a lot of those free light chains, it's going to have implications a little bit in terms of prognosis. But also, it's got a shorter half-life than IgM. So if you start a treatment, and the free light chains will come down a lot quicker than the IgM will come down. So it's sometimes helpful, especially for patients who have, for example, plasma exchange as part of their treatment. So if you really start treatment, do plasma exchange, it's hard to monitor the IgM very well during that time because it's being removed. And so the free light chain assay can be a little helpful in those situations too. And it's prognostic, and actually there's one study that found, well, levels over 80 could be associated with, a shorter time to needing treatment. And so I think there is implications for the serum free light chain. The majority of the time probably not essential, but I think for some patients it could be very helpful. And they track with the other things. So this is the, free kappa for a patient along with their M spike, and you see the similar graphs. We like to see graphs like this. Actually, for us, it's the opposite of Wall Street. If you see things going down, we're happy. So I'm going to stop here. We have 8 minutes for questions. I guess maybe more, but I'm going to stop here and take questions. This is the group at Moffitt, and we got a nice group, and some of the lymphoma docs, also CWM, some of the myeloma docs, CWM. So we have a little bit of a large group. And I've been there 17 years in Tampa. So it's been a lot of fun. We like it. All right. Thank you for attention. And we'll take questions.
For those in your practice who have cryoglobulinemia, the 2% who are symptomatic, I found that even when you keep the blood samples warm, supposedly they're warm all the way to the lab, that I can get a low IgM number, even in the regular range. And then I've been 3 days later, and same thing, kept warm, and it's been 1,200, 1,500. So have you any answers for how that could happen? Have you seen that yourself? Yeah,
we have seen that, and it's challenging, as you say, because it's always the term supposedly kept warm. I'm always skeptical. We tell the phlebotomy, and then we tell the lab to label those samples appropriately and to keep them in a higher temperature, like a body temperature, but it doesn't always happen. Sometimes, it's all done perfect until it gets to the machine, and then it sits next to the machine for like 10 minutes, and then you're on it. And so I think the key thing is to try to emphasize, and even at our center, it gets a little challenging because, my nurse does all those precaution, kind of puts all that information in the computer, in terms of warning, the phlebotomy and the lab and all of that stuff. And then there is somebody new in phlebotomy and they don't look at it somehow. So I think it happens a little more with, like centers like Quest, I have a little bit more trouble with. But at our own center, it's a little better, but it's not perfect, as you mentioned. So that gets very challenging.
Thank you for that very complete explanation. I was curious about platelets. So I'm one of those with low platelets, and I was wondering how low is too low?
Yeah, so it depends, I think. Like we said, it's like, spontaneous bleeding in the absence of anticoagulant or aspirin usually shouldn't happen under, when the platelet count's over 10,000. People could have surgery, say a gallbladder remover, if the platelet count's over 50,000. Sometimes some of those, in between, it's, we have a grading system for low platelets. So if it's under 50,000 but over 25, it's technically called grade 3, and that's severe. And then grade 4 is under 25, so that's actually more severe lowering of platelets. So these are all markers of usually understanding the low platelets that come as a result of treatment. So if, for example, somebody receives bendamustine, their platelets could go low about 10 days later, and let's say it reaches, say, 20,000 or 15,000, then maybe the next time around you probably should give them a little less bendamustine or rethink the plan. But those should recover. Sometimes, as Steve showed, we give bendamustine and counts could be low for about 9 months or a year later. And that could be very challenging, and we have to manage. And during this time, with sometimes transfusion support. But if the platelets over 10,000, we usually are not transfusing. So under 10,000, we transfuse because the risk of spontaneous bleeding is high. So I don't know if that answers the questions.
Yep, thanks.
A large spleen can also sequester platelets, and sometimes that can, cause a little bit of a lowering of the platelet, but in those cases, it's usually in the 70, 80,000. It's not in the, 10,000, right? Yeah.
Is the IgM produced by Waldenstrom cells different from the IgM produced by normal cells?
It is different in that it is clonal, meaning it comes from the same clone. It is the unique type of, it's the same protein for all those ones that are produced by the Waldenstrom, whereas the one produced by the immune system have different affinity to different targets. And because of that, sometimes this affinity to different targets, some of the targets could be in our body. Like, for example, myelin-associated proteins, which is on our nerve endings. And in that case, that IgM itself is the problem then. All right?
Do you see any lung involvement with Waldenstrom's?
Okay, you got to go again. I couldn't hear you.
Do you see any lung involvement with Waldenstrom's?
I have seen lung involvement. A lot of times when I see involvement with an LPL infiltrate in the lungs, you're usually looking at this condition called MALT, which is very common in the lungs. Well, it's more common in the lungs than Waldenstrom is in the lungs. So you have to make sure that it is not a related type of lymphoma. But do we see it? Yes, we have, yeah. Okay.
Hi, Dr. Baz. Would there be any value in measuring our T cells? I don't know if that would be through blood work or not, but would that provide any good information for patients?
Yeah, we have many different types of T cells, and there are, flow-based method to measure different types of T cells, and we can look at, for example, CD4 T cells, CD8 T cells, and there are times we measure this, especially after cellular immunotherapy or basically T cell redirecting therapy, because very low CD4 T cells put patients, for example, at risk for a type of pneumonia that we need to, give medicine to prevent. But for the majority of the times in patients with medicines we're using for WM more commonly, this is not necessary, and it won't get to that level that, it would impact management. So while that can be done, a lot of the time it is not necessary for the most common situations. Yes.
So
I'd like to say to you and all the doctors here, I know in your training and your residency in medical school, you got tired and weary and you thought, why am I doing this? But I appreciate what you've put in. I'd say this to all the doctors here, that what you've done helps people like me, so thank you.
Oh, thank you, actually.
This is helpful. I'm learning more about my own medical reports, and maybe I'm confused. We've always understood in my medical reports that the abnormal protein was the M spike, and that's reported in grams per deciliter, and my number went from 1.1 to 0.1. So is abnormal protein the M spike? Or in your chart that you showed, I have serum numbers, and it shows albumin and the alphas and the betas, and I have gamma globulin. And gamma globulin is the M spike?
No, the abnormal protein band is the M spike. That is one of the terms that, so other words for M spike: monoclonal gammopathy, monoclonal spike, monoclonal band, abnormal protein, some labs call it. The gamma part is this whole gamma fraction. So this is the gamma fraction. This is usually where the M spike resides. The lab measures the whole gamma fraction, but they can also measure that M spike, or the abnormal protein band in your case. So usually they're going to track together, but the more accurate measurement for the protein itself is actually going to be the abnormal protein band. Does that?
And I realize my numbers, actually I don't have a number for what the IgM level is in my test. I thought it was the abnormal protein number multiplied by 1,000 to give 1,500.
No, not exactly. The IgM is measured separately with a totally different test than the monoclonal protein. It's called nephelometry, and it's a more direct measurement. This looks like a direct measurement, but actually the pathologists have to put a few bars around this and decide, well, this is where it starts, this is where it ends, and we're going to quantitate this. So that is a little bit of subjectivity when you measure the M spike. And for the majority of the time for patients with WM, the IgM is a very good surrogate instead of necessarily worrying just about the M spike. We measure both because of those, some of the differences, discrepancies in the lab that you sometimes get. But the IgM should be reported separately from the electrophoresis test. Well, thank you, everybody. I think it's lunch now.